for joining today. I'm Flora. I'm one of the Echo Fellows at St. Mike's. And today I'm going to be talking about the basics of myocardial strain. So my objectives are threefold. The first is to discuss some basic concepts of myocardial mechanics, which we can't really do talk about strain without talking about mechanics, and the basics of Speckle tracking echocardiography and what the essential concepts of that are. My second point is to discuss technical and practical aspects for measuring LV strain, given we have lots of sonographers here, and this is predominantly imaging tech talk. I want to focus on how we can optimize our measurement and get the best strain values. And then finally, I'll just discuss some factors that influence LV strain and their corresponding clinical applications. The talk in itself from a clinical application of strain perspective can be very extensive, so we'll only touch on that more briefly, but focus more on the first two objectives.
So the inspiration was because strain felt like a bit of a black box. I could see the inputs. We see very colorful images that the sonographers have taken where there's tissue tracking, but then I would get a number of average GLS, and at the end of the day, that's really all I reported. I would just put the GLS number on the report, and that would essentially be it. So I would get an output, I would get an input, but don't really understand what it was doing, what the actual machine or the software was doing in order to calculate a number for me and what necessarily that number means. So I thought that I thought I would do a little more reading about it, and this is why I thought I would do this talk today. So I'll first start off with what the definition of strain is. Strain is really like a physics term as well. It's essentially equivalent to deformation, which is often discussed similar in the same vein of strain. And essentially can be applied to any object where there's a relative length change in that object within a certain direction as a result of some force. So you can place strain obviously on LVs and ventricles and atria, but also on any objects we're talking about. It's a dimensionless number because, as you can see, strain by calculation is based on a change in length, which is the numerator, over the original length, which is a fairly simple conceptual idea, and it's unitless, and it can be negative or positive because you can change length in either a negative or positive direction. Strain rate is simply the rate of deformation, so how quickly that change in length occurs. So in terms of the myocardium, when we look at it on 2D echo moves, we can see various directions. We can see longitudinal movement, we can see wall thickening, which is radial, but it actually also moves in various other directions, such as circumferential, rotational, or torsion or twist. So the motion or mechanics of the LV is actually quite complex, and it's very much dependent on the myocardial fiber structure or architecture of the LV. And what's interesting is that this occurs as a result of the difference in orientation of the different layers of myocardium. If we actually look at the myocardium can be separated into the sub-endocardial layer just below the endocardium, a mid-wall layer, and a sub-epicardial layer. And what you see is actually they're formed by two helices of opposing directions. So in the sub-endocardial layer, they actually describe this as a right-hand helix. So if you take your right hand, you can actually, if you think about your fingers, you're wrapping the fingers around in a helix. That's one direction of the sub-endocardium. So the sub-endocardium is a right-hand helix. In contrast, the sub-epicardium is a left-hand helix. So again, if you take your left hand, you think about the fingers and how it could be wrapping around like a helix. They're actually in opposing directions, whereas in the midwall, it's circumferentially oriented. And when you combine these motions and fiber architecture together, what you actually see is that in the basal portion, as a result of the sub-epicardial orientation, in the basal portion, the rotation is actually in a clockwise direction, whereas in the sub-endocardium, the rotation occurs in a counterclockwise rotation. In contrast, in the apex, you see that the rotation as a result of the sub-epicardial orientation leads to a counterclockwise rotation, and similarly in the subendocardium, it's the opposite. It occurs in a clockwise rotation. And so the major determination, actually the dominant forces, are of the subepicardium. And so at the base, if you look at the base, it will actually rotate in a clockwise direction, as seen by the arrow at the top here. And in the graph on the left, my mouse might not be showing up. And then if we look at the apex, it actually rotates in a counterclockwise rotation like that. So in essence, what you get is this differential rotation in the opposing direction, the base to the apex, and you almost get a ringing motion that you can see, for example, if you were to wring a wet towel, you squeeze all the water out, and this actually increases the mechanics, or it provides the mechanics of how blood is ejected from the LV. Now, strain in the LV can occur on multiple planes, as I mentioned, in circumferential, longitudinal, and radial planes. And we can also describe it as both normal strain and something called shear strain. And normal strain is essentially strain where you apply a force perpendicular to the surface. So, for example, if we were applying a force on this y-axis, we would push this, along the x-axis, and this is normal strain. This can be done from longitudinally, circumferentially in the LV, or radially, which is essentially thickening of the wall. There's also something called shear strain, which is actually sort of a sideways movement. So if you were sliding this box, this red box, along that plane into this dotted line, this is shear strain. It's sliding of one plane over another. And in the circumferential and longitudinal planes, shear strain is also known as torsion. So these are all the different ways. As a 3D structure, the LV is quite complex. As you can see, it has multiple ways of normal strain and multiple ways of shear strain that it can move. And the purpose of shear strain is actually to increase the ability of that LV to eject blood. At 15% shortening longitudinally can actually be translated to 40% radial thickening, and that will lead to over 60% change in the LV ejection fraction in normal hearts. And so by this mechanism, the LV is able to really efficiently pump blood. There is a bit of a gradient from the subepicardial to subendocardial in terms of shear stress. And that gradient is actually in the direction of increased shear stress as you go from subepicardium to subendocardium. And this is just relevant because, of course, we're sampling sort of different layers of the myocardium when we look at strain. And it's helpful to understand that there is a slight gradient as you do this. So one of the major benefits of strain is that we can actually look at dysfunction from a layer-specific perspective, although technically how that it can be done is challenging. But we can see that if you have a disease or myocardial disease affecting certain components of those myocyte layers, you can actually affect different parts of LV mechanics. So, for example, if you have predominant subendocardial dysfunction, which is actually what predominantly affects when myocardial disease affects early on, it primarily causes subendocardial dysfunction. Because the subendocardium is oriented more longitudinally, it governs more predominantly longitudinal motion. And so you get impairment, significant impairment in longitudinal mechanics, with actually compensation by circumferential, radial, and torsional mechanics so that you preserve LV ejection fraction. In contrast, if you have a predominant dysfunction affecting the subepicardium, it will tend to affect the other portions more than longitudinal, so circumferential or torsional mechanics, and the other parts of the LV mechanics tries to compensate and preserve EF. And once you really get transmural dysfunction affecting all of these fiber layers, that's when you can get dysfunction of the mid-myocardium, the subepicardium, and lead to significant impairment on all of these mechanical measures and have a global reduction in LV ejection fraction. LV ejection fraction, as you can see, really integrates actually all of these mechanics, longitudinal, circumferential, radial, using this volumetric method. But it doesn't necessarily, it's not able to really decipher between longitudinal, circumferential, or radial changes or dysfunction. So coming to how we actually can look at strain non-invasively, there's multiple imaging modalities we can do this with. Of course, echocardiography is our standard at this moment. And within echo, there's actually two types of ways we can do that. Both one is tissue Doppler and the other is feature and speckle tracking. which I'll go through. But because this is solely based on echo, I'll talk about the echo components, but also to remind us that there's also cardiac MRI that can be used for measuring strain. And they use a very similar technique of feature tracking, or we can use tagging in cardiac MRI. So first I'll talk about tissue Doppler imaging and strain using tissue Doppler. This was actually the first description of strain by echo, was using TDI. And this is essentially when we look at diastolic measures, when you put the marker on the annulus and look at E primes, we're looking at diastolic tissue Doppler velocities. In contrast, when we look at strain, we're looking at systolic velocities. And what we can do is actually, when we put this ultrasound beam across these myocardium and determine tissue velocities, we can actually derive the strain rate, because they're basically velocity. If you, for example, look at this image on this side, velocity at two different points, spatially differentiated points in the myocardium, subtracted from each other over a set distance, L usually set at 10 millimeter, actually derives the strain rate of that myocardium. And then further, because you know the temporal, the time that it took for that strain rate to occur, you also can derive the strain and the shortening. So this was actually the first way that we did this. And the main benefit of TDI is that it has very high temporal resolution. Of all the techniques from Speckle tracking, TDI actually has the best temporal resolution. However, it was very dependent on angle, because you had to make sure your scan line, your ultrasound beam, was scanning across the motion, the motion of the myocardium that you were looking at. So if you were looking at longitudinal motion, you had to scan, obviously, to be as parallel to the motion of the myocardium as possible. And if you were not aligned, you actually needed to perform angle correction. If you were at 90 degrees, it would be very tough to really get any appropriate strain value. And so this was much more challenging to determine circumferential strain where you needed, or radial strain where you need to be on the short axis. And so it was really mainly restricted to looking at LV longitudinal strain from the apical windows. In addition, the TDI method also had increased susceptibility to noise. So there was a lot of noise associated with this. And so as a result, what we are using more is strain by feature and speckle tracking. Now, speckle tracking echocardiography can actually be conceptually quite simple, because although the technical aspects are very complex, but conceptually it's simple, because all it means is that we're taking grayscale digital images, which are just the 2D echo images that you guys have acquired, and applying a computer algorithm to try to track the motion of these speckles. And so we talk a lot about speckles within the myocardium. So what are the speckles? They're also called the features, and they're basically not actually tissue structure itself. They don't represent tissue. They represent the inhomogeneous acoustic properties of the myocardium that causes an interference pattern that creates these appearance of these speckles or dots within this black myocardium. They don't represent tissue structure, but they move with tissue structure over a specific time and distance. So if we track the speckles, we can track the motion of the myocardium. And that's essentially the concept of what speckle tracking echo is doing. The important part of this is that when we look at strain, we can look at intra-tissue velocity. So we can look at the myocardium itself and look at the speckles within the myocardium to understand their motion or deformation. In comparison, we can actually look at active motion. In comparison, if you're not necessarily looking at intra-tissue velocities, you might see motion, but that could be because of passive displacement, either because of it's being pulled or stretched from other segments, or because of global cardiac motion. So it's moving in your field of view because of respiratory motion, for example. So this really looks at within the tissue itself, these velocities. When we do speckle tracking, what occurs, and I'll go into a little bit more in depth in terms of the algorithm workflow, but we typically first begin by defining a region of interest that we're interested in looking at the speckle tracking in. The computer algorithm divides it into a bunch of blocks of pixels, usually made up of about 20 to 40 pixels, and they essentially track the stable patterns of these pixels over the next subsequent frames. And they try to search for the new location of this frame, and then try to find the next block of pixel patterns that is as closely matched to the first one to understand where it has moved in these subsequent frames. And ultimately, the change from frame to frame gives us spatial information in terms of its movement. So as you can see on the left side here, this is frame 1 plus n, whereas here this was frame 1. So there has been a change in the relative length between these two speckles in the pattern, and the computer can determine the spatial change, as well as they have temporal data based on ECG gating and knowing what how much time has passed as well within this period of time. And so they can calculate actually a velocity vector in terms of the motion. And using strain formula, we can understand if it's positive or negative, if it's thickening or thinning, or if it's shortening or lengthening, depending on the axis that we're looking at. So this is a general workflow of strain algorithms. Basically, all strain algorithms use the same typical workflow, and I'm just going to go through how that actually happens. So the first step is really to detect end diastole and end systole. We need to give the computer algorithm understanding of what part of this cycle is systole and where we want to track the myocardium. There's actually different ways, as we know, to define end diastole and end systole, and the same thing with the software. There's different ways that the softwares can actually make this determination. We can do this manually. We can look for closure of the mitral, for end diastole, the closure of the mitral valve, which is the frame before that would be considered end diastole. We can do it by ECG gating with the beginning of the QRS or the peak R wave in some cases. We can manually tell it by looking at the largest diameter of the LV, or we can use the peak of a GLS curve that's generated, which is actually the most positive. So that's end diastole just at around the beginning of the QRS. And systole can be defined as the frame following closure of the aortic valve. This is the most typical or most common definition. You can also use ECG gating with end of the T wave to help determine that, or the smallest LV volume, or the nadir, or the lowest point of the GLS curve would be considered end systole. The next thing that the computer needs you to do is to define a region of interest. Essentially, we want to look at strain over the myocardium. And so this can be done either manually or semi-automatically by the software, with some adjustments by the user. And what we do essentially is contour the endocardial border, as well as in some cases the echocardial border. I'll talk about how there can be layer-specific assessment. And this typically involves contouring end diastole, and then some softwares will also ask you to do it in the end systolic frame as well. The next step is to segment the regions of interest that you've defined. And segments are basically the anatomic units for which strain analysis will be reported. And this is one of the advantages of strain, is that we can look at segmental or regional function, which we not able to do with LV ejection fraction. The segmentation is based on what we typically think of as the usual 16, 17, or 18 segment model. You can, different softwares can choose between 16, 17, or 18 segments, although they differ slightly because, for example, in the 18 segment model, this is an example on the right-hand side, where you basically segment each of the apical 3, 2, and 4 chambers you acquire into 6 different segments, 3 on the left side, 3 on the right side, and you distribute the apex quite equally across 6 segments. All of the idea is that all of the segments should have the same end diastolic length so that they're fairly equal. So when you average the segments, it should give you pretty close to if averaging the global strain. But if you segment it differently in 16 or 17 models, you can weigh the segments differently. You can weigh the apex differently because it may be divided into 4 or it may be divided into 5. And then mathematically, you're averaging all of those segments means that you're actually weighing them mathematically the same, even though segmentally they're not exactly the same length. So there's segmentation creates some degree of variability in your strain value as well. And then finally, the computer, once you've given out all this information, will then start performing tissue tracking and then generation of strain curves, and it will output, these curves that we normally see in both the global strain as well as segmental or regional strain. How does it actually do this tissue tracking is an interesting part of strain analysis as well, and this can really, my understanding of it is quite simplified as well. But having done some reading on it, it uses basically techniques that are popular for tracking objects within a video sequence. So if you were tracking a person in a video, you may use some of these what's called optical flow methods to actually track motions and understand how fast that person's moving or over what time, how much distance was moved, for example. One of the most commonly used is this technique of block matching. And it basically can be quite simply explained in this graphic here. So so on your first initial frame 0, so time 0, you have this frame where we've identified a region of interest. The computer also looks at this region of interest in blue. In the next subsequent frame, some motion has occurred, which the computer doesn't actually know what it is at this moment. So what it tries to do is it formulates a search region, let's say. And within the search region, it tries to look at all the possible ways that region of interest that in blue could have moved. It could have moved to this side, this side, this side, or this side. These are all possible movement or motion directions. And then it tries to find tries to compare this region of interest, the original region of interest, with all of these other blocks, and tries to match it to the most likely pattern that was found in the original blue block. And once it's found it, it will consider that as the best matching region and infer that those speckles within that original blue box has moved to this dashed blue box here. And so using various statistical analysis, it can determine most likely it's moved here. And then with this, again, spatial and time difference, it can generate a velocity vector. And once we do that for multiple regions of interest blocks, and we can analyze the motion over these successive frames and estimate the motion of the entire myocardium using this technique of block matching. There are also other techniques that can be used, one of which is elastic registration, which is a little bit different. This is more used in the research rather than in our clinical softwares, but I thought this is of interest. So again, if you have frame 1 here in the beginning, you have some motion that has occurred into frame 2 or the second frame in the next successive time point. And again, the computer does not know exactly what motion has occurred, but it can try to measure it by using elastic registration, which essentially applies like a grid over this image. It then warps the grid so that it also warps the underlying image and deforms the underlying image. And it does that, variations of that to try to find where you get the warped image would be most matching the ultrasound image that's actually obtained, the true ultrasound myocardial image obtained. And so once it's found it's matched, then it says, okay, this is probably most likely where the motion has been. And then it uses this grid to understand how each of the speckles has moved in this grid. So these are, outside of our usual concepts that we think about, but they're more almost computing algorithms that can be used to figure out strain and deformation. Coming back a little more practically in terms of what we're doing, we can analyze strain on, when we analyze strain, we draw these lines across the myocardium, and the tissue tracking occurs along these lines. And how does it determine whether it's a circumferential, longitudinal, or radial strain? It's basically whether that motion is tangential to the line you've determined. So, for example, here, this is the LV myocardium in sort of an apical 4-chamber view, let's say. You can draw your line either at the endocardial border, at a mid-myocardial, or at the epicardium. And anything that's motion that's tangential to that line that you've drawn is considered longitudinal in apical views. And anything that is in short axis views, tangential is considered circumferential. In comparison, if it was moving perpendicular to that line that you've drawn, then that's considered radial motion. So we can put this line in the epicardial, endocardial, or mid-myocardium, or we can tell it to give us strain across the full myocardial thickness by averaging all of those measurements. The actual clinical significance of doing it layer by layer is unclear at this moment. Most softwares default to endocardial border, and so that's what we typically use. But the reality is whether we can even resolve these very specific layers using our current probes and lateral resolution is unclear at this moment, and there is really no clear significance of layer-specific strain analysis. So ultimately, when we want to acquire all these different strains, we need a couple of different views. So in longitudinal strain, we want all 3 apical views. In radial strain, we want all 3 apical views plus parasternal short axis views, because all of in perpendicular movement in the short axis also is thickening and is radial strain. And then for circumferential strain, we only need short axis views only. One of the major things to talk about that the software actually applies to the strain analysis suite, or the tissue tracking that it generates, is something called data regularization. And this is important because this generates a lot of, or it can generate the variability that we typically see in strain values. And what this basically means is that the software actually tries to manipulate the values that it's given it to put some constraints on it so that the motion it occurs similarly to what is expected LV motion. So it tries to avoid distorting the geometry of the LV shape too much, because when you have all these motion estimates, it can be very noisy. And so it tries to constrain itself to what it would consider as expected myocardial motion based on data sets that has been given in the past. And so in some ways, there is a cosmetic that's applied to almost like a filter that's applied to the strain values that come up, that the motion estimates that are actually determined using tissue tracking, to try to smooth the motion of the tissue over space and time. So it's different from the raw data that we see, for example, in tissue Doppler imaging, which is the velocities, the exact velocities that are given to you are the velocities of the myocardium. Whereas here, there is some degree of computer manipulation of that data to make it more smooth. So it's possible where there is, where there's abnormal motion, the computer has sort of softened it or normalized it in some ways. Where there's pathologic motion, the computer could actually fill in some holes and make it look more like normal motion rather than truly pathology. So I talked about the different modalities for strain assessment, and there's lots of strengths and weaknesses of them. They obviously use different measurement methods, as I mentioned. We have TDI, which uses velocity determination and derivatives to strain rate and strain. It has very good temporal resolution, but like I mentioned, it can be very noisy and can be angle dependent. 2D Speckle echo tracking echo is very good at looking at regional and global strain. It can be semi or fully automatic. Important things that you actually don't need dedicated acquisition. We just need to get the images, the 2D images that you normally get in your echo, and apply that algorithm on top of it from the software. It's apparently less noisy than in TDI, but it also suffers from a lower resolution than TDI, as I mentioned, which has one of the highest temporal resolutions. It's very dependent on inter-vendor differences, which I will talk about, and there's a strong influence from this regularization of algorithms, or this cosmetics that's applied to it. There is the availability of 3D speckle tracking echocardiography, but there is a lot of limitation. It's not used clinically at this point because of low feasibility, lack of standardization. There's a lot of differences in vendors, and it has very low, actually, temporal and spatial resolution at this point. But it has the advantages of being able to look at out-of-plane motion. So in 2D, the LV may have moved out of the plane that you're scanning in, and we won't be able to capture that necessarily on 2D. And there can also be foreshortening that happens on 2D, which can be accounted for in 3D speckle tracking echo. So what do we get when we do actually apply these computer algorithms to the images that we obtained? So this is the strain output that's given to us. We're pretty familiar. This is on the GE platform. As you can see in the A panel, you have the 2D image with this contoured region of interest that's outlined, and they color coded depending on the cardiac motion. So the brighter the redness, the more shortening, or the more shortening has occurred. And then it can give you regional strain values with all the segments that it's defined, and represent the values in here. Again, color coded in this red line that you actually see along the myocardium is just coding to suggest how much shortening has occurred. Red being more shortening, white being, or less red being less shortening. It also give you the strain curves over the entire cardiac cycle. It shows you what it's defined as aortic as end systole, which is here aortic valve closure, and it gives you the strain curves for each segment. It can also display it in sort of a color M mode, such as in D, in panel D here. So across the cardiac cycle, it shows you the color based on that scale that I was talking about, more red being more motion, more shortening. and less red being less motion, less shortening for each of the segments. And then finally, it displays all of the segments in a bullseye plot, which we very commonly see as well. So the strain values we get can be segmental or can be a global strain value. The global strain value can be calculated in actually different ways. It can calculate strain along the entire myocardial line that you've defined, or it can take all the segmental values and then just average them. Those, like I mentioned earlier, mathematically can give you different numbers if you've weighed your segments differently, if the segments don't have the same length. The other thing is that it can define the exact value in terms of the strain value. It gives you the global strain value. Although they call it global systolic strain, it can be actually at different time points, and that's something to note as well. So we have a standard strain curve here. As you can see, there can be a peak positive strain that obviously is at end diastole. There's a peak systolic strain, which is the nadir of that strain curve during systole. There can be an end systolic strain, which is what you defined as the end systolic marker, and there can even be post-systolic strain. So it's important for us to know actually which part of the strain, which strain value the computer is actually giving us back. This default for most vendors is actually the peak systolic strain, although some of the consensus statements have recommended end systolic strain. Practically, most of the vendors give us a peak systolic strain value. So when we have strain values, we something I just wanted to point out is the positive negative values of them. So as we can kind of deduce circumferential and longitudinal strain, because there's in systole the LV shortens, will lead to negative longitudinal strain values and negative circumferential values. Radial strain will actually be positive because of the fact that there's thickening during systole. And when we try to compare strain values over time, which is one of the major applications, is to understand strain in patients over the course of, for example, chemotherapy, we want to actually, the standard is to use the absolute value of the number to compare between one value and another. So when we talk about an increase in GLS, for example, we want to look at the absolute number. So if it goes from 18 to 20, this is actually an improvement in LV function. If it decreases from 18 to 16, this is a deterioration in LV function. We want to use just standard wording to describe strain in order to allow for comparison. So why do we tend to emphasize on global longitudinal strain and not the other strain patterns that I described, circumferential or radial? There's a couple of echo imaging practicalities that improve our ability to, or the quality of longitudinal strain rather than circumferential radial strain. First of all, when you look at movement in the axial plane, so movement longitudinally of points that are moving longitudinal to each other, this actually has superior resolution than looking at points that are occurring lateral to each other. The global value obtained from the mean value across the entire, we can actually obtain a global value from mean values across the entire myocardium rather than, for example, in the short axis, we might be scanning just at one layer, whereas in apical views, we can obtain multiple apical views, in 2, 4, 3 chambers, looking at the entire myocardium. There's also more myocardial tissue that we're looking at in the apical long axis and the short axis views, and usually non-hypertrophied ventricles. And so for that reason, we're actually obtaining more myocardial tissue, more strain analysis on more of the myocyte motion. So this will give us a more robust measure. And really, at this moment, the reproducibility of radial and circumferential strain is not sufficient for clinical applications. So our focus has really been on global longitudinal strain. So in terms of the practical aspects of GLS assessment, I wanted to just go through what are some of the things we can do to try to optimize and ensure we have as best of a value as possible. This is actually a stepwise strain measurement algorithm that was produced as part of the SECORE trial, which was a trial examining strain surveillance for patients receiving cardiotoxic chemotherapy. And because they were so focused on strain analysis, they needed to make sure that there was high quality sonography scanning as well as high quality readers to make sure there was sort of uniformity. So practically, in terms of what we want to get when we have to get a good optimal GLS assessment is, first of all, image acquisition. So this is really where the sonographers come in. And like I said, we can apply strain analysis on just 2D echo images, but ideally we want to make sure we have as good of an endocardial and myocardial visualization as possible. We want to avoid foreshortening because there's actually a minor gradient in GLS from the base to apex, higher at the apex. We want to avoid shortening as much as possible to avoid issues with that. Generally, we want to acquire the frame rate at about 60 to 80 frames per second to optimize temporal resolution. We want to use breath holding as much as possible to avoid motion as a result of respiration. And although GLS assessment is often cited as angle independent compared to TDI, we still ideally want the scan line to go across the motion of the myocardium. Because of the anisotropy of echo images, there can be dropout in some cases if you're not exactly in the optimal incidentating angle. And so it's still the best spatial resolution is obtained when the scan line is along the deformation axis that we're looking at. So if longitudinal, we want to be as parallel to the longitudinal motion of the LV. In terms of selecting the region of interest and segmentation, the most important thing is actually we want to visually check the tissue tracking and whether it's tracking appropriately. And remember, we're tracking longitudinal motion and we're not looking at thickening, which is what we are more normally attuned to when we look at wall thickening, which is actually more radial strain. We want to be careful at the annulus and the apex. We want to avoid including any things like the pericardium, the papillary muscle, or the trabeculation. We want to avoid ROI that is too wide or too narrow, which too wide can include the pericardium. And we want to exclude segments that are poorly tracked, especially after 3 attempts to try to optimize it. It's probably not going to be optimally tracked at that point. And where there are stationary image artifacts like reverberations or where they're simply not well seen. And if in one view you have more than 2 segments that can be tracked, GLS is considered not reliable at that point. And this is based on the 2015 AAC guidelines is what they have recommended. So just to give some examples of where we can, have faults. So the importance of ROI selection is identified on this slide here. In the top images here in A and B, you can see that the line that's been drawn is actually all the way out in the apical septum, all the way out towards almost the pericardium. And so it ended up tracking more of the pericardium, and the strain value was here at negative 17.2%. If we bring it in and actually focus it on the actual endocardial borders and not track the pericardium, which reduces GLS, the GLS becomes higher at negative 29%. So there's actually a substantial difference even with a single segment that's poorly tracked or inaccurately tracked that can substantially affect your GLS values. The other thing to note is you want to exclude the papillary muscle. So in this example here, the tracking has included what's over here is actually a papillary muscle. And then it's actually overestimated the strain in the apical segments. And if you correct that, to not include the papillary muscle, the strain value is lower. The other important thing is that because it uses a regularization algorithm, it tries to impose as much of a normal myocardial shape as possible. So when you have fairly distorted shapes of the myocardium, the algorithm can become very confused and doesn't know how to track it appropriately because it's out of the shape of what it's normally been taught. So those are some things to be aware of when you're tracking. The other important things to think about is looking at the basal segments. You want to avoid overly including what's past the mitral annulus into the left atrium. As you can see here, it will on a whole reduce our strain values. And then in the apical 3 chamber, you want to avoid going too far into the LVOT, which again can reduce our strain values. The width of the ROI is also important. I don't know if all the softwares allow us to choose the ROI. Sometimes it's applied automatically, but if the ROI is very big, then it can over-include and go into the pericardium. Again, that will reduce GLS values. And then if it's too narrow, you get less the variability that you're seeing within the myocardial motion may be more restricted because you're really focused on a more narrow aspect of the myocardium, and that can give the appearance of more motion. There's less variability, and you can actually overestimate the global longitudinal strain. Aortic valve closure time definition is also very important. As you can see in this panel on the right side, And A and B, this is exactly placed right at the end of the T wave, which is the most appropriate end systolic or aortic valve closure time. Ideally, you want to assess aortic valve closure visually on this apical 3-chamber views to determine when the aortic valve closure actually occurs. But if you can't do that, you can kind of define it at the end of the T wave. But if you define it too early, such as in C and D, you will get very different regional strain pattern as well as a lower GLS. And if you define it too late, again, you'll get a very different pattern with very different values as well. So this is another thing to pay attention to that can generate variability. And then, of course, within the vendor itself, there's a lot of variability that can happen exclusive of the operator and the ways that we choose ROI or the ways we segment. Like the things I mentioned, whether it looks at the endocardial, epicardial, midline, or full thickness, that can be built into the algorithm, and it's important for us to know which one it's using. Like I mentioned, layer-specific strain has really questionable significance. Segmentation differences, whether it uses a 16, 17, or 18 segment model. The regularization algorithms are proprietary to themselves, and so we don't really understand much of it. This is part of the black box of strain, I suppose, and so that can create a lot of variation. Definitions of end systole and end diastole also creates variability in the vendors and the software. The width of the ROI that's determined, and the method of calculating global strain. So whether we're looking at averaging or calculating strain across the entire myocardial line versus we are averaging the segments can give you mathematically different numbers depending on your segmentation. So the ESC actually, in combination with ASE and the industry task forces, have actually created a common definition for 2D speckle tracking echocardiography for all of these definition, all of these variability, to ensure that the vendors specify what it is doing with the software and to try to standardize it as much as possible. But despite that, we still see a lot of inter-vendor differences. And this is actually a study of normal of 62 patients of varying LV function, and they looked at 7 different vendors, 2 software-only vendors, so they don't make ultrasound machines, but they only make software. And you can see there's a lot of variability of strain, average GLS strain from negative 18% all the way to 21.5% in the same population. And the blue dots down here signify significant differences between these different vendors. Just to focus on GE and Philips, because we have a lot of GE and Philips machines, GE tends to overestimate, so they tend to actually have a higher value than Philips strain values. What's interesting is that they also looked at inter-observer variability of these softwares. And there is, again, still quite a bit of inter-observer variability. But I wanted to point out is that when we look at the calculation of LVEF by biplane, it actually has more inter-observer variability than any of the strain values by these vendors. So the reproducibility of strain is thought to be higher than LVEF for this reason, despite the fact that there's so much variability that can be occurring with our strain values. Variability can also come in clinical factors. Patients of different race and ethnicity have different strain values. That's been studied across various populations. Age, as we age, the strain values GLS specifically tends to decrease. Males actually have a lower strain value on average than females across all age groups. And hypertension, obesity, patients with diabetes on dialysis are all associated with lower GLS, of course, for various pathologic reasons as well. And then athletes have a significantly higher GLS than normal sedentary individuals, which we've seen in studies. So with all this variability, we're now, what is actually considered normal strain? So how do we assess that? And the reality is the current guidelines we have, which are the 2015 ASC guidelines, don't provide normal values simply because of so much variability, both from an operator standpoint, vendor standpoint, clinical patient standpoint. The ballpark or the rule of thumb is that average GLS of approximately minus 20% plus minus 2 is normal in healthy individuals. There's actually was a very recent study of reference ranges of GLS for all cardiac chambers done in Norway. Of course, this is a very specific population. The mean age was 57. although they had over 1,000 individuals who were considered healthy and normal. And in their case, LV GLS, the lower limit to normal was actually negative 16%. So there's certainly a lot of variability and a lot of differences in the literature, but accepting less to about negative 16% is something that we do see in the literature as well. This was also the first study to actually provide reference ranges for all cardiac chambers, including the RV and the atria. So in the last few minutes, I know I'm running out of time just because we started a little bit late. I wanted to briefly touch on some of the factors that actually affect strain value and how that applies in clinical conditions. First of all, it's important to debunk the myth that strain is load independent, because it's not. It is load dependent. We know that strain decreases as you decrease preload and decreases as you increase afterload or with increased heart rate. Geometric factors also affect strain values. So a larger LV is actually known to have a lower strain amount, even though it's able to produce the same stroke volume. Similarly, LV that have a higher wall thickness, independent of decrease in contractility, they actually have decreased LV strain. They are able to maintain the same LV ejection fraction by other means, by compensating with circumferential strain, for example. So different geometric remodeling of the LV can lead to different strain values without necessarily a change in myocardial contractility. And of course, myocardial tissue characteristics such as deposition of scar or fibrosis, scar, deposition of either infiltrative disease or storage disease, leading to deposition of various proteins within the heart, can lead to abnormalities in strain. As we know, toxic agents in HCM, the myocardial fibril disarray, also leads to various amounts of strain abnormalities. And one thing that I mentioned earlier is that the subendocardial fibers are typically the first things that are affected, and because they are predominantly involved in longitudinal shortening. This is one of the reasons why longitudinal shortening can be an early sign of myocardial dysfunction that is not necessarily seen by LV ejection fraction. And this has been one of the cornerstones of why strain is so helpful. The other benefit of strain is actually can be in detection of ischemia. As within seconds of ischemia, there's actually a reduction in systolic shortening. And we can also see something called post-systolic shortening, which you can see in this curve here. In these segments, in the basal inferior and the mid-inferior, there's actually the peak systolic strain occurs after aortic valve closure or after in systole, and that actually could be because of delayed relaxation that happens. And so when we do see post-systolic shortening, this could be an indication of ischemia in these territories. It's not specific though, it can be because of scar or localized areas of HCM or Fabry's disease. And then we have various, as we use strain, we are pretty well aware of the inhomogeneous tissue characteristics leading to these various regional patterns of strain differences. And this becomes somewhat of a pattern recognition assessment now. And these are things that we're all very familiar with. For example, apical sparing, typical cardiac amyloidosis. In this patient, there is hypertrophic cardiomyopathy, as you can see by the increased basal septum, and there's decreased strain in the hypertrophy segments. In this patient with apical hypertrophic cardiomyopathy, we can see regional strain reduction in the apex. And then in this patient with an apical infarct, you can see reduction in strain in the apex. Strain can also tell us about dysynchrony of the myocardium, where there's, because of its ability to segment the LV and look at regional deformation abnormalities. So the host of clinical applications for strain is just expanding exponentially. As we can see, this is just a list of all the research that's ongoing and where we've already had some use of strain. So it's a very important, I think, and ongoing area of research and expanding clinical applications. So I'll just end it there. For the sake of time and take any questions or discussion points. Thank you.